Recording in progress.
Hello everyone, it is Dr. Swati Singh for Anesthesiology Rank Decider question for INICET from DocTutorials. So I hope whatever questions I have brought for you, a few questions definitely can come from this, as I have tried to assemble the questions, seeing what trends we were getting from previous years of the question. So let us start our discussion with the questions. I hope you had a good test. And if you have prepared well, these were not difficult questions to solve. They were from the expected topics. So the first question, a 4-year-old child posted for herniatomy surgery under caudal anesthesia. All true about caudal anesthesia except. So they are asking that which of the following sentence is false about caudal anesthesia? So let us see the options, and then few things I'll talk about the caudal anesthesia, and then we would know which statement is false. So it is a common regional anesthesia technique in pediatric patient. Okay. It is a special type of spinal anesthesia. It is commonly used for postoperative analgesia for urological and lower abdominal surgery. It is easy to perform in pediatric patient less than 1 year of age. So which statement is false? So let us see what exactly is caudal. I know you must be knowing what is caudal anesthesia. Well, if someone can give me the answer in the chat box, I would be very happy. So if you can give me the answer in chat box, meanwhile, I'm trying to explain the caudal anesthesia, I'll be more than happy. So what is caudal anesthesia? Well, if I say the first line, the answer would be from the first sentence itself. Caudal anesthesia is sacral epidural anesthesia. Good evening. So can I get a question from any one of you? Caudal anesthesia is a special type of epidural anesthesia. It's a sacral epidural anesthesia. So caudal is sacral epidural anesthesia. Okay. So what do I mean by sacral epidural anesthesia? I mean that when I give the epidural anesthesia in the sacral space, right? So that is what is called caudal anesthesia. So I am also happy to see you all join DocTutorials, Karthik, and I hope you all enjoy the questions which I have assembled for you. So as I was continuing, that caudal is special type of sacral epidural anesthesia. When we give epidural in sacral space, we call it caudal anesthesia. So your epidural anesthesia can be given in thoracic space. It can be given in lumbar. It can be given in sacral, depending for what surgery we are using it for. For thoracic surgery, we use it for thoracic epidural anesthesia. So as I said, for thoracic surgery, we use thoracic epidural. For abdominal surgery, we use the lumbar epidural. And for the lower abdominal and your rectal surgery, lower abdominal and rectal surgery, we are using sacral epidural, which is also called caudal anesthesia. So the statement, it is a special type of spinal, this is incorrect, absolutely incorrect statement. It is special type of epidural. So this statement is incorrect. Now, first statement, it is a common regional anesthesia technique in pediatric. Now, why caudal? See, it is a special regional anesthesia technique which we use specifically in pediatric patient, because in pediatric patient less than 5 to 6 years, the sacral hiatus is unfused. If you see, this is the epidural space, right? This is the epidural space, okay? And we are putting the needle in the epidural space in the sacral area, we call it caudal. And when we reach the sacral epidural space, we pierce sacrococcygeal ligament. So one very important question which can be asked on caudal, that what is the last layer which you pierce to reach the caudal space or sacral epidural space? It has to be sacrococcygeal ligament, which is modification of ligamentum flavum. See guys, ligamentum flavum is the last layer which we pierce to reach the epidural space. And in the sacral area, it is modified into sacrococcygeal ligament. So this is one expected question which can be asked on the caudal. The second, what is there that your sacrum, which is a fused bone, the S5 and S4 lamina of the sacrum is unfused in pediatric till your age group of 6 to 7 years. So this unfused sacral lamina, this produces a space. This is called sacral hiatus. And this, through this hiatus, with a simple needle, we can pierce the sacrococcygeal ligament and we can enter the caudal space. So this is a very common technique, one of the most common technique. So this is most common regional anesthesia we practice in pediatric. Regional anesthesia in pediatric patient, right? So less than 6 to 7 years for lower abdominal, for the urological procedures, we put caudal through which we maintain the analgesia of the patient. So the statement that it is common regional anesthesia technique for pediatric patient is correct. It is commonly used for postoperative analgesia for urological and lower abdominal surgery, correct. It is easy to perform in pediatric patient less than 1 year. Actually, this is not absolutely correct statement. I would say it is best to be performed in less than 7 years of age, 7 years old, right? But which is more incorrect statement? Why I have picked up this question and why I have put two options which seems correct, just to give you an idea for INICET exam. You know, in INICET exam, there is one thing which I have noticed, that number of time two options seems correct. So what you have to mark is the best possible answer, right? So in this question, I would have been happier if the last option would be less than 7 years old. It is easy to perform in less than 7 years old. So less than 1 year is within less than 7 year old. So this is not entirely incorrect option. So I would deal it as a correct option. Which is entirely incorrect option? It is a special type of spinal anesthesia. This is absolutely a false statement. So I would go this for an answer. So 1B. So how many of you have done given the right answer for this question in the test? I hope you have given the right answer. And thank you for welcoming me, everyone. Very happy to join DocTutorial and very happy to be your anesthesia faculty. So next question. Again, a question I have chosen on regional anesthesia, obstetric anesthesia. I want to discuss few points about obstetric anesthesia. Any question asked on obs anesthesia, with this question, we can solve it. So question is regarding a patient for lower section LSCS under general anesthesia, which of the following statement is incorrect? So for LSCS, that is a obs patient under GA. So first thing which we need to know is LSCS, the most common anesthesia. This is a favorite question of exam. So I will come on it. First, let me see the question. Regarding a patient for LSCS under general anesthesia, which of the following statement is incorrect? Supine hypotension can be prevented by putting a wedge under right buttock. Okay. Selleck's maneuver can prevent aspiration of gastric content. Uncuffed endotracheal tube is preferred due to airway edema. Considered as full stomach always. So which is incorrect statement? So let us talk few things about obs anesthesia, and that would solve all your question on obs anesthesia, I promise. So let us talk about obstetric anesthesia. So obstetric anesthesia, what do I mean by it? I mean when I have to give anesthesia to get LSCS done. Okay. So what are the different type of anesthesia which can be used for LSCS? So I know immediately what will come in your mind? Spinal anesthesia. Yes, guys. For LSCS, the most common form of anesthesia practiced worldwide is spinal. So yes, I would write spinal anesthesia as the first anesthesia of choice for LSCS. Okay. For any reason, I cannot give spinal. What would be my next choice? It would be epidural anesthesia if I can give epidural and I cannot give spinal. So these two, regional anesthesia and combined spinal epidural anesthesia. These three regional anesthesia technique can be used for LSCS. But if we have any contraindication for all these three techniques, Then we can go for general anesthesia also in LSCS. So guys, so many times in my lectures, I have told you that regional anesthesia has specific indication and some absolute contraindication. So spinal, epidural, they have specific indication and some absolute contraindication. And if the patient, my OBS patient, has one of those absolute contraindication, then I'll have to go for general anesthesia. Anesthesia, general anesthesia, which doesn't have any contraindication. Any kind of surgery, any type of patient can be taken under general anesthesia. But why do I prefer spinal for OBS patient? Why not GA? Well, for few reasons. First reason, that your OBS patient, they are at a high risk for aspiration because their GI motility is very poor. So anytime they have had your food, we consider them full stomach. So reservations, I'm writing reservations for general anesthesia in OBS patient. Number one, they had high risk for aspiration. High risk for aspiration. So anytime they had their meal, even 12 hours back, 24 hours back, full stomach. We always practice rapid sequence induction intubation in them if I am giving general anesthesia. So remember, they are high risk for aspiration. Second point, my reservation, why I don't want to give GA to a OBS patient, and I have to give it only if there is a contraindication for neuraxial blockade, spinal and epidural. The second reason why I don't want to give GA, they have a difficult airway. Difficult airway. So their airway is edematous, their airway is difficult to secure, and they are one group of patients in whom we always consider to shift the airway card and then intubate them, difficult airway card, because in high percentage of OBS patient, we find difficulty in securing the airway. Okay. Then the third reservation why I don't want to give GA is immediate bonding between child and mother would be lacking. So immediate bonding between child and mother, and mother would be lacking. So this is not possible because reversal from GA would take some time. Now, fourth reservation, the GA drugs, which we give intravenously, especially if I have to give opioids prior to the taking out of the fetus, there's a risk that because of the placental transfer, it can go to the fetus. So transfer of drugs to fetus. So this is my 4 reservation why I don't want to give GA. So what is my anesthesia of choice? Spinal or epidural or CSC, combined spinal epidural. But GA, we have to give if I cannot give these anesthesia for absolute contraindication if there is in the patient, like coagulation disorder, right? If patient has a coagulation disorder, I cannot give the neuraxial blockade to the patient. If let's say patient is a severe cardiac disease patient, I cannot give neuraxial, I'll have to give general anesthesia, right? Okay, so let us see the question again. Supine hypotension can be prevented by putting wedge under right buttock. Any OBS patient, 20 weeks more pregnancy, coming for being transferred from one place to another, coming for any surgery, whatever kind of anesthesia I'm giving, spinal, epidural, GA, we put a wedge under right buttock to prevent supine hypotension. Supine hypotension is due to pressure of gravid uterus on the great vessel, that is aorta and your inferior vena cava. This can decrease the cardiac output and produce hypotension in the patient. So putting a wedge while keeping the patient on the OT table or transferring the patient is must. So this is a correct statement. Selleck's maneuver can prevent aspiration of gastric content. I told you, these patients high risk for aspiration. So we always do RSI, rapid sequence induction intubation. So Selleck's maneuver is applying pressure on the cricoid during RSI. So this is application of pressure on cricoid during RSI. So we do it to prevent the aspiration of gastric content. This is a correct statement. Uncuffed ET tube is preferred due to airway edema. Guys, these patients are high risk for aspiration. So we always prefer to put a cuffed ET tube. Uncuffed ET tube would never be preferred, right? So cuffed ET tube is what we will prefer in them, right? So this is incorrect. Considered as full stomach always? Yes, I told you. Anytime they had their meal, we always consider them full stomach. Okay. So C is incorrect answer. Uncuffed ET tube is preferred due to airway edema. We always prefer cuffed tube. So remember, in them, they are high risk for aspiration. We practice RSI and we prefer cuffed tube, right? Remember this. Okay. They are difficult airway. So we always shift airway, cart, and then proceed for airway manipulation. So these are the important things that we need to know about the anesthesia for OPS. One more thing I want to add. Spinal anesthesia is the most common form of anesthesia we give in LSCS patient. Now, any comorbidity patient has. For all normal patient, we give spinal. Patient has any comorbidity without absolute contraindication of central neuraxial blockade, right? Patient has severe hypertension or patient is preeclamptic, then we prefer epidural because epidural produces less hemodynamic instability, okay? And if patient has absolute contraindication for central neuraxial blockade, then we prefer GA. So spinal, if patient has no contraindication, so I'm writing for LSCS, spinal anesthesia, if patient has no contraindication for spinal and patient has no comorbidity. So if patient has no comorbidity, I would prefer spinal anesthesia. If patient has no contraindication for your central neuraxial blockade and has some comorbidity, right, then I would prefer another neuraxial blockade, epidural anesthesia. Why? Epidural causes less hemodynamic imbalance than spinal. And general anesthesia would be preferred only if patient has absolute contraindication for spinal and epidural anesthesia. Got it? So GA is the last choice. If spinal and epidural, we cannot give. Spinal is the first choice. But if there's a comorbidity in which we don't want a rapid hemodynamic alteration, we can go for another neuraxial technique, which is epidural anesthesia. So this is how you have to approach for the answers in the question. No contraindication, spinal. It is described patient has a hypertension or eclampsia. Which anesthesia would be preferred? Epidural. And if patient has some absolute contraindication for central neuraxial blockade, you have to look for the absolute contraindication like coagulopathy or severe heart disease or raised intracranial pressure. Then we go for general anesthesia. Got it? So this is the second question. Next question, a very, very important topic for exam. I think this is one topic from which every year there is a question and you cannot make a mistake in this topic, right? Give the correct match regarding advanced cardiac life support being given to a patient during cardiac arrest resuscitation. So this entire question I have prepared, keeping in mind that you need to remember the flow chart, which is necessary to remember for managing a patient in cardiac arrest, the ACLS, Advanced Cardiac Life Support System flow chart. So first, let's say option is, and first point is definitive management in ventricular fibrillation. Okay, so they have asked definitive management in ventricular fibrillation. Second, after first dose of adrenaline, next drug given in asystole. So this is another rhythm of cardiac arrest, asystole. First point was on VF. Second is on asystole. Okay. Third, after first dose of adrenaline, next drug given in the pulseless ventricular tachyarrhythmia, another rhythm of cardiac arrest. And fourth, during resuscitation, team was unable to achieve IV access. Now what they will do. So these are the four things. So this would cover your entire ACLS algorithm, which you have to know. So options, I will come on the options. Once I discuss the algorithm with you, then I will do the match the following. So this first point, which we need to know in ACLS management, that cardiac arrest has 4 rhythm. In cardiac arrest, there are 4 rhythm which is possible and it's divided into 2 groups, shockable and non-shockable rhythm. Shockable rhythm, that is ventricular fibrillation and pulseless ventricular tachyarrhythmia. These two are shockable rhythm. As you can see, VF is just irregular lines on ECG paper. It has no morphology, nothing. So this is VF. And this is VF. And these are shockable rhythm. And pulseless ventricular tachycardia, there is a formed morphology. There is a formed morphology, but the heart rate is very high. So heart is not getting time to get refilled because diastolic time has very much reduced. So in both these VF and VT, the heart has gone brisk. The heart has gone brisk. So the definitive management when the heart goes erratic or brisk is to give shock and stop the heart momentarily so that when the heart resumes its rhythm, it could be sinus rhythm, which is the natural rhythm of the heart. So definitive management of shockable rhythm is defibrillation. So what is the definitive management of shockable rhythm? It is defibrillation. So this is the definitive management of shockable rhythm. Non-shockable rhythm, which is asystole, which is a straight line, and pulseless electrical activity, that is PEA. Okay. Now, asystole and pulseless electrical activity. In asystole, there is no electrical activity, so we would never defibrillate. And in pulseless electrical activity, there may be a normal electrical activity, so we need not defibrillate. So these are non-shockable rhythm. So what is the definitive management for non-shockable rhythm? There is no definitive management of non-shockable rhythm. So what do we do in non-shockable rhythm? We only do CPR and try to find the cause why patient has gone into cardiac arrest. So we do CPR and try to find try to find cause why patient has gone into cardiac arrest. Got my point, right? So here we never defibrillate. So how do we manage shockable rhythm and how do we manage non-shockable rhythm? So this is a flow chart that we have to remember. So shockable rhythm is VF and VT. The definitive management is shock. After giving shock, we do CPR for 2 minutes. We secure IV IO access. Again, after 2 minutes, we see the rhythm. Rhythm is still shockable. Again, we give a shock. We do CPR and we start giving emergency drug. That is, epinephrine is the first emergency drug. Then, if possible, we intubate the patient. Again, 2 minutes gone. We see the rhythm. Rhythm is still shockable. We give the shock and we give another emergency drug, amiodarone. So, in shockable rhythm, shock is one intervention apart from CPR. ADR, adrenaline, is another intervention which we can do, and amiodarone is the third intervention we can do. But what about non-shockable rhythm? That is asystole and pulseless electrical activity. We do CPR, we never give shock. We give adrenaline as soon as possible, and we continue doing CPR and we try to find the cause, treat the reversible cause to reverse the patient. So no amiodarone, no shock. So amiodarone is not given in non-shockable rhythm. Okay, so let us just, after revising this flow chart, let us see what would be the correct match the following. So definitive management of ventricular fibrillation, well, defibrillation. So for one, this seems the right defibrillation. After first dose of adrenaline, next drug given in asystole. So asystole is non-shockable rhythm. And in non-shockable rhythm, there is no other drug apart from adrenaline. So what do? We give, what is the next drug? Adrenaline, adrenaline, adrenaline. That's what I say. For non-shockable rhythm, it's adrenaline, adrenaline, adrenaline. There is no other drug. So the second drug is your adrenaline again. After first dose of adrenaline, next drug given in your pulseless ventricular tachyarrhythmia, which is a shockable rhythm, would be amiodarone. So next drug in shockable rhythm can be after adrenaline, amiodarone. And during resuscitation, team was unable to achieve IV access. What could be the alternative route? Well, if we cannot achieve IV access, we go for intraosseous access. Not central line, nothing of that sort. So fourth would be, the B would be the correct option for fourth. So 1C, 2A, 4B, and 3D. So let's see. 1C, 2A, 3D, and 4 is your B. So D would be the right answer. Got it? So 1A is the, sorry, for 1 it is C. Sorry, C is the right answer. So this is not right. C is 1C, 2A, 3D, and 4 is your D. Okay, so C is the right answer. So keep it in mind. This is a very important question on your ACLS. So very quickly, just few more things I want to revise for the ACLS. One, CPR quality. Questions are asked on quality of CPR. So just you have to remember 5 important points for high quality CPR. High quality. Guys, in CPR, the quality has to be high. There is no compromise. There couldn't be anything less than 100%. And what is 100% CPR? What is high quality CPR? 5 points. Number 1, push hard. How hard? At least 5 centimeters. So push hard, at least 5 centimeters. Number 2, push fast. How fast? Between 100 to 120 compression per minute. So 100 to 120 compression per minute. Then third, allow complete recoil. So complete recoil should be allowed. If you will not allow complete recoil, the next compression would be a useless compression. Number 4, minimum interruption in chest compression. So minimum interruption in chest compression. So chest compression should be of best quality and it should have minimum interruption. So first 3 things tell us about the best quality chest compression. Fourth, minimum interruption. And the 5th point is just adequate ventilation. We should not over-ventilate. Just adequate ventilation. So these are the 5 points for high quality chest compression. High quality chest compression. Got it? Okay, next thing which can be asked, shock energy. So today we are using the bipolar defibrillators, and normally the energy which we use is 120 to 200 joules, or whatever is recommended by the manufacturer for giving the shock for defibrillation, or between 120 to 200 joules. So this is the shock energy. First, if I am starting with 120, subsequent shocks we can increase with 20 joules. So 120 to 200 joules. Next, drug therapy in cardiac arrest. There are 2 important drugs for shockable rhythm. For shockable rhythm, it is adrenaline, 1 in 1 milligram, 1 in 10,000. And we have amiodarone, that is amiodarone. And remember, amiodarone, only 2 doses, 300 milligram and 150 milligram. 2 doses. First dose 300, second dose 150 milligram. See, adrenaline 1 milligram, 1 in 10,000. We repeat every 3 to 5 minutes. So remember, there is no upper limit of adrenaline. There is no upper limit. We can go on giving it as long as we want, as long as we are doing the resuscitation. Amiodarone, only 2 doses. And if we don't have amiodarone available, then we can go for lidocaine. Lidocaine is an alternative to amiodarone. So this is for shockable rhythm. For non-shockable rhythm, that is your asystole and pulseless electrical activity, it's only adrenaline, no other drug, nor amiodarone, nor lidocaine, right? So this is, you have to remember, in drug therapy, no other drug, guys. So whatever intervention drugs I'm telling you, that are the only drugs. Don't keep a drug from your mind like atropine or sodium bicarbonate. These are not drugs which we use in managing a cardiac arrest patient. Whatever I'm mentioning, whatever is in the flow chart should be in your mind, nothing else. What my point? So never imaginally produce a drug. So don't think sodium bicarb, calcium gluconate, calcium chloride, all sort of drugs I hear. No, guys, these are the only drugs. Okay. Then ROSC. What is ROSC? Return of spontaneous circulation. Return of spontaneous circulation. So remember, guys, ROSC or return of spontaneous circulation. How do we know it? ROSC has been achieved. 2 things could be helpful. Number 1, the capnograph. The reading of the capnograph, let's say it is coming 25, 30, suddenly it will increase. So this will indicate that ROSC has been achieved. And the second thing is, we will feel the pulse if we will palpate the pulse. Okay. So this is very sensitive. Even before I feel the pulse, by seeing the graph of capno, I would know return of spontaneous circulation has happened and my CPR is successful. Okay. What are the reversible causes of cardiac arrest? Reversible causes of cardiac arrest, we have to remember 5 H's and 5 T's. So I know you all must be knowing 5 H's and 5 T's. So what are 5 H's? Well, 5H, hypoxia is the first one. Then hypovolemia. Hypovolemia is the second one. Potassium, hyperkalemia. Hyperkalemia. Acidosis, that is H plus ion. And your hypothermia. So these are the 5H. These are the reversible causes of cardiac arrest. If we send an investigation and we see anything of this happening in the patient, I would immediately target it, and that would reverse the cardiac arrest. 5Ts. What are the 5Ts? First T is your tension pneumothorax, then your tamponade, cardiac tamponade, right? Then is your thrombus, the pulmonary thrombus, and the coronary thrombus, right? And toxin is the fifth one. So these are the 5Ts. So if a trauma patient, I will immediately auscultate when I'm ventilating to see that is it pneumothorax. Tamponade, I will auscultate, and maybe I can find, right? Or if I suspect tamponade, I would shift the ultrasound machine, bedside ultrasound machine, and I will diagnose tamponade. And I would do a pericardiocentesis. So these are the reversible causes which would help us in managing cardiac arrest patient. So this is what we have to remember in ACLS protocol. Anything can be asked, all are important. So coming on the next question. Next question is from very, very important topic, mechanical ventilation. Questions on mechanical ventilation nowadays, I'm seeing it's being asked very commonly. First question. So the question, sorry. A 50 kg patient with acute lung injury was put on mechanical ventilation on assist control volume mode with the following setting: tidal volume 420 ml, respiratory rate 17 per minute, IE ratio 1:2, PEEP 10, and FiO2 0.9. Patient was hemodynamically stable. What change should be done in following setting after seeing the ABG, pH 7.35, PaO2 72, and PaCO2 34 mm of Hg? So options: tidal volume needs to be decreased, FiO2 should be decreased, no change required, PEEP should to be decreased. Okay, guys. So these kind of questions nowadays I'm seeing very commonly being asked. They give you a mechanical ventilation setting, they give you an ABG report and ask you to do the changes in the setting. So remember, why do I put a patient on mechanical ventilation? A patient is put on mechanical ventilation to maintain his oxygenation and ventilation if he is unable to maintain on his own. So for oxygenation and for ventilation, a patient is put on mechanical ventilation. So I am putting a patient on mechanical ventilation for maintaining oxygenation and ventilation. Okay. So what are the parameters of ABG which will tell us about oxygenation, and what are the parameters which will tell us about ventilation? So for oxygenation, guys, when I see the ABG report, I have to see PaO2. And for ventilation, if I'm seeing the ABG report, I'll have to see the pH and I'll have to see the PaCO2. Okay. So what would be the normal range of pH? 7.35 to 7.45, PaO2 72 to 104, and PaCO2 between 35 to 45. These are the three parameters that we have to pay attention on. Okay. Normally, what are the things which can improve the oxygenation of the patient? Now, when I do a ventilatory setting, we set, let's say, assist control mode. We set the tidal volume. Normally, we start with 6 to 8 ml per kg body weight of the tidal volume. Now, this is responsible for maintaining the ventilation. And if PaCO2 is not being maintained within the normal range, or pH is decreasing, the ventilation is what is getting affected. So I would have to increase the tidal volume. Respiratory rate, normally we set within whatever patient was originally taking the respiratory rate before putting on the ventilation. So let's say 12 to 18 breath per minute. So if ventilation is getting affected, to increase the minute ventilation of the patient, I can increase the respiratory rate, I can increase the tidal volume. So your respiratory rate and tidal volume, which is minute ventilation, and this is responsible for maintaining the PaCO2 of the patient. If PaCO2 is above 45, then I would alter respiratory rate and alter the tidal volume of the patient, right? If patient's PaO2 is less than 60, normal is between 80 to 104 at, let's say, room oxygen concentration. But if we never intervene and increase the FiO2 if the PaO2 is above 60. So if the PaO2 is below 60 mm of Hg, so there are two ways by which we can improve the oxygenation. One is by increasing the FiO2, fractional inspiratory oxygen concentration. Another by increasing the PEEP, that is positive end expiratory pressure. This PEEP, this prevents the collapse of the alveoli. So PEEP prevents alveolar collapse. This was asked in last exam. Why we apply PEEP for a patient on ventilation? Because it prevents alveolar collapse and it allows oxygen and CO2, O2 and CO2 exchange from a wider surface area. And by increasing FiO2, I can increase the oxygen concentration of the patient, right? As we breathe more oxygen concentration, more will go into the blood. So FiO2 is another way of increasing the oxygenation. But both have their demerits also. High FiO2 can cause oxygen toxicity, and high PEEP can cause barotrauma and hemodynamic instability. So what we do, we titrate at what minimum FiO2 and minimum PEEP, the oxygenation is just maintained. So normally we keep the setting of the PEEP, we start with 5 centimeter of water and we increase it according to the requirement of the patient. So this PEEP maintains the oxygenation of the patient. And FiO2, whenever we start a patient on ventilator, we start with 100%, that is FiO2 of 1, that is 100% oxygen. But gradually we decrease it to non-toxic level of FiO2, that is less than 60%. So this is our priority, to decrease the FiO2 if the parameters are within normal. And this also maintains the oxygenation. Inspiratory flow, we keep it between 60 to 100 liters per minute, depending upon the respiratory rate of the patient. So forget about the inspiratory flow, only concentrate on these. So first two is maintaining the ventilation, and the third and fourth is maintaining the oxygenation. This is maintaining oxygenation, this is maintaining the ventilation. So let us come back in our patient. Now my patient, the pH is within normal limit, that is between 7.35 to 7.45, it's within normal limit. PaO2 is above 60, so again it is normal, and PCO2 is also normal. So whatever setting I have done, it has achieved oxygenation and ventilation. But if I see the setting, the FiO2 is very high. It is a toxic FiO2. So my first responsibility is to bring it to the non-toxic level. So I would decrease the FiO2 as we have achieved the oxygenation. So I will start decreasing it. I will make it 0.8, 0.7, 0.6, and that is what is our target. 0.6 is the non-toxic FiO2. Got my point? So once I achieved 0.6 of FiO2 and still oxygenation is being maintained, then I can decrease the PEEP as well. PEEP as well. Got my point? So then I can decrease the PEEP as well. But first thing is we have to bring the FiO2 to non-toxic level. So FiO2 should be decreased. Seems the right option in this question. Okay. So keep it in mind. So this is the answer. Okay. So remember the ventilatory setting, what we do, what are the things which we do to improve oxygenation, and what are the things we do to improve ventilation of the patient. So already I have talked. For oxygenation, we have to increase FiO2 and we have to increase the PEEP. For ventilation, we have to increase the tidal volume and we have to increase the respiratory rate. Okay. So at what minimum FiO2 and minimum PEEP, oxygenation is achieved. Target oxygenation is PaO2 should be above 60 mm of Hg, right? Target ventilation is PaCO2 should be below 45 mm of Hg. Okay. Okay. Next question. Again, match the following question. Match the following intravenous anesthetic agents for clinical condition where they are agent of choice. So where they are agent of choice. So ketamine, these are IV anesthetic agent and where they are agent of choice. Ketamine, options: neurosurgery, neuroprotection, neurology of fallout, cardiac dysfunction, anxiolysis. Okay. Propofol, Option saying the etomidate, thiopentone. So guys, propofol, it is agent of choice for what condition? So let us come back on this question in a moment. Let us come back on this question in a moment. Okay. Let us discuss where they are agent of choice. Okay. So thiopentone. Remember, for anesthesia, I'm talking about where they are agent of choice. Remember, thiopentone for anesthesia is nowhere agent of choice. So for anesthesia, thiopentone is now no longer preferred, nowhere agent of choice. But there are two places where thiopentone is drug of choice. One, it is drug of choice for neuroprotection. Neuroprotection. Got it? So for neuroprotection, it is drug of choice for cerebral protection and for narco-analysis. Narco-analysis. So for narco-analysis and neuroprotection, thiopentone is drug of choice. Remember this. What about propofol? It is agent of choice in multiple conditions. You know, propofol has replaced thiopentone. Okay. Yes, Sam, I'm just coming back on your query which you have put. Can ketamine act as a cardiac suppressant also? Yes, I would just come back on that query. Propofol is at varied places agent of choice. I would come in a moment where it is agent of choice. Etomidate is a cardiostable agent. So it is agent of choice for patient with mild to moderate cardiac dysfunction. So patient with cardiac dysfunction, I would go for etomidate. Etomidate is a good agent for cardiac surgery. What about ketamine? Ketamine is the best agent, anesthetic agent for shock. It is best agent for shock. Patient in shock, ketamine is a sympathomimetic. It will increase the blood pressure and heart rate. So it is the agent of choice. And wherever we want the blood pressure of the patient not to fall, ketamine is agent of choice, as in cyanotic heart disease, like tetralogy of Fallot. In cyanotic heart disease, we don't want the systemic pressure to decrease and the shunt fraction to increase. So it is agent of choice in tetralogy of Fallot. That is your cyanotic heart disease. Remember, guys, ketamine is a cardiac depressant. It is cardio unstable agent. Where it is depressant in a moment, I will tell you. But it is cardio unstable agent. But it is only one cardiac surgery where it is agent of choice, and that is tetralogy of Fallot. That is cyanotic heart disease. Okay. And ketamine is agent of choice in bronchial asthma because it is best bronchodilator. So shock, bronchial tetralogy of Fallot, and bronchial asthma. It is agent of choice, right? Mild to moderate heart disease, cardiac dysfunction, etomidate is the agent of choice. And rest, anything comes in your mind, guys. Anything means anything. That is daycare surgery, neurosurgery, thoracic surgery, malignant hypothermia, porphyria, anything, renal dysfunction, hepatic dysfunction. I mean, you go on suggesting, I will go on writing. Anything comes in your mind, propofol is anesthetic agent of choice. So it is as simple as this to remember. Thiopentone, nowhere agent of choice for anesthesia, but two places drug of choice, narcoanalysis and neuroprotection. And neuroprotection is different from neurosurgery, mind you. Okay, etomidate is agent of choice for cardiac surgery, mild to moderate cardiac dysfunction. Ketamine is agent of choice in shock, tetralogy of Fallot, that is a cyanotic heart disease, and bronchial asthma. And for rest, everything, what should be answer? Propofol, propofol, propofol. So propofol is agent of choice, anesthetic agent of choice in your daycare surgery. I mean, I'm writing some and I would not write many. And I'm writing the things which are most commonly asked. Neurosurgery, right? Neurosurgery, got it? Your, let's say, thoracic surgery, let's say your malignant hypothermia, porphyria, for renal dysfunction, for hepatic dysfunction. I mean, go on writing. I won't stop you because for everything else is propofol that we are using. Got it? Only issue with propofol is it is cardio unstable. So we try to avoid propofol in cardiac dysfunction. If ketamine is not available for tetralogy of Fallot, for bronchial asthma, I would use propofol, but best is ketamine because it is best bronchodilator. So only thing with propofol is it decreases blood pressure. It is a cardiac depressant. It decreases blood pressure. It is a cardiac. It causes cardiac dysfunction. You are getting my point? So we are not using propofol. We are not using propofol wherever we don't want the blood pressure to decrease. So we don't want blood pressure to decrease in shock. We won't use it. We don't want blood pressure to decrease in cyanotic heart disease. We won't use it, right? So we would only use it where we have a stable patient. Got it? So these are the conditions in which propofol is agent of choice. So Sam asked me that is ketamine a cardiac depressant? Guys, so next thing I want to discuss effect of these agent on cardiac, on heart. Thiopentone and propofol, cardio depressant. Both decreases blood pressure and decreases myocardial contractility. Okay. Etomidate, cardio stable. Right. Ketamine increases blood pressure and heart rate. It increases blood pressure and heart rate. Got it? Ketamine is sympathomimetic. It is sympathomimetic. It increases blood pressure and heart rate. In absence of catecholamine, it is myocardial depressant. Guys, remember, a drug is cardio unstable if it increases blood pressure and heart rate also. It is unstable. If it decreases blood pressure and heart rate, it's a cardiodepressant also. If a drug is cardiostable, it is having no effect on cardiovascular system. Then only we say drug is cardiostable. And that's only etomidate. So this is a question. That it increases blood pressure and heart rate, so best in shock, but it can also cause myocardial depression. So I hope, Sam, you got the answer. Yeah. So these two things I wanted to discuss with this question. So what would be the answer? For ketamine, it is agent of choice in tautology of Fallot, propofol in these neurosurgery. For etomidate, cardiac dysfunction, and thiopentone for neuroprotection. So 1 is C, 2 is A. So let me see. 1 is C, 2 is A. So this B is the answer. Got it? So B would be the answer. So I hope your query is properly attended, Sam. If any more query, you can put in the chat box. So let us see the next question. Okay. 6th question. A patient had a road traffic accident and was brought to emergency during primary approach. His airway seemed obstructed. What maneuver should be taken immediately to open the airway? So obstructed airway. What maneuver? And patient is a patient of trauma patient, road traffic accident. Whenever we have a patient with an obstructed airway, there are 2 maneuver which comes in our mind. Only and only 2 maneuver. If you see the image, these are the 2 maneuver. The first one is head tilt, chin lift, and the other one is jaw thrust. In head tilt and chin lift, we tilt the head backward and lift the chin upward. This lifts the tongue away from the posterior wall of the airway. And in jaw thrust, we just keep the head and neck in neutral position and we protrude the mandible forward. So this is jaw thrust and this is head tilt chin lift. As you can see in head tilt chin lift, there's movement on head and neck joint. So we would not use it as first maneuver in trauma victim. So this would be best for non-trauma, the head tilt and chin lift. And what would be best for the trauma victim? Jaw thrust. So for this kind of question, 2 things you have to, 2 type of question can be asked. 1, image-based question. So image can be there and they can ask what maneuver is being performed. So this image is head tilt chin lift, in which my 2 hand is doing 2 things. One is tilting the head backward, other is lifting the chin forward, and the other is jaw thrust, in which head and neck is in neutral position and both my hand is cupping the side of the face and protruding the mandible. This lower 3 fingers are lifting the mandible or protruding it forward. So this is jaw thrust. Got it? So image-based question, very, very common. And then a clinical question, as I have formed one, that is patient is of road traffic accident, that is trauma, and we have to open the airway. So as I said, in trauma, jaw thrust would be the first maneuver. So head should be extended. This alone would not do the job. Head tilt chin lift in non-trauma. Jaw thrust is what should be the answer. And morning sniffing position is your laryngoscopy position. Laryngoscopy position. This is the position we make for laryngoscope. Got it? So this we have to keep in mind. Okay. So this is about the question on airway opening maneuvers. Okay. Next, again, a very, very important question on airway, which I expect can be asked. So this device has been given and they asked to identify the device and how to choose the correct size. So first you need to identify the device. So this is a device which has a beveled end and it has a flange on the top, and there is no marking on the body. This is nasopharyngeal airway. This is nasopharyngeal airway or NPA. And how do we choose the correct size? This is a device which we insert from nose, remains in the pharynx, creating a passage for the air to pass. So how do we choose the right size? By measuring from tip of the nose to ear lobule. The right size has to be chosen before inserting it. It comes in an assorted size. So I would just show you a few images, then I'll come back on the options. Okay, so these two devices in the image, both are the simple airway adjuncts. These are the basic airway device or adjunct. What do we use them for? We use them to create an unobstructed airway. This is oropharyngeal airway. The most common one we use is oropharyngeal airway. The most common one we use is your Goodell's airway. And first question would be on image to recognize it. So you can see it is curved with a bite block to recognize it. And this is a flange, which prevents its migration in the oral cavity. And this has a channel throughout the body. Okay. This is nasopharyngeal airway. Nasopharyngeal airway. Now, this nasopharyngeal airway is made up of silicon or PVC. It has a soft body. It is not curved like oropharyngeal airway, fixed oropharyngeal airway made up of plastic fixed curve. Nasopharyngeal airway straight with a beveled. This is the beveled end, like ET tube's beveled end. Okay. And so to recognize, you have to remember the image. The second thing which is asked, how to choose the correct size. Oropharyngeal airway in its body lifts the tongue, and nasopharyngeal airway creates a passage for the air to pass. So they have different works. This lifts the tongue, oropharyngeal airway, and nasopharyngeal airway creates a passage for the air to pass. Got it? Okay. How to choose the correct size of oropharyngeal airway? By measuring from angle of mouth to angle of mandible. Angle of mouth to angle of mandible. Okay. So we measure from angle of mouth to angle of mandible. And nasopharyngeal airway from tip of nose to your ear lobule. Okay. So these are the another questions which are asked on these two devices. Then the third question, guys, oropharyngeal airway is made up of rigid plastic. So we don't use it in conscious patients. So this is the device of choice in unconscious patient. And nasopharyngeal is device of choice in a conscious patient with obstructed airway. Any patient can have obstructed airway, conscious, unconscious. If patient is conscious, I would use nasopharyngeal. If patient is unconscious, I would use oropharyngeal. Okay. So these are the three questions which are possible on these simple airway adjunct, basic airway adjunct. So this is a nasopharyngeal airway. And how do we choose the correct size? By measuring from tip of nose to ear lobule. So B is the right answer. So I showed you the oropharyngeal airway. This is not oropharyngeal airway. Uncuffed tube. Well, uncuffed tube may look similar, but it will have markings on it. Nasopharyngeal airway doesn't have any markings on it. Remember, and tube will always have a connector attached on its other end, the end which will be attached to the circuit. This doesn't have a connector. It has a flange attached to it. So I cannot attach a circuit to this nasopharyngeal airway. It can only be attached to the tube. Got it? So it is easy to recognize. It has a beveled end. It has a smooth body with no markings on it. Okay? Nasopharyngeal airway. Okay, next question. Okay, question on reversible agent. A patient posted for emergency surgery, rapid sequence induction was planned, and rocuronium 1.3 milligram was used as neuromuscular blocker. During attempted laryngoscopy, the airway was difficult to secure. The anesthesiologist planned to reverse the paralysis. So we were doing rapid sequence induction, right? Modified rapid sequence induction, because the modification which we did, instead of succinylcholine, I used rocuronium. So rocuronium is the neuromuscular blocker belonging to non-depolarizing neuromuscular group, which can replace succinylcholine in modified RSI. Why do we use succinylcholine for RSI? We use it because succinylcholine has fastest onset within 30 seconds. Okay. But rocuronium, if I cannot use succinylcholine for any reason, I can use rocuronium, a non-depolarizing neuromuscular blocker. Now, rocuronium in the dose 1.2 to 1.3 milligram per kg body weight can also give a fast induction within, let's say, fast paralysis within, let's say, 90 seconds, So a little more than succinylcholine, but much faster than other non-depolarizing. So rocuronium can replace succinylcholine for RSI. So in this, anesthesiologist has done the same. He is using rocuronium. He doesn't want to use succinylcholine. But the issue is that succinylcholine has shortest duration also. Its duration is hardly for 7 to 8 minutes. But rocuronium is intermediate acting. So it acts for 45 to 50 minutes once it is given. So if I am unable to secure the airway, there is a problem. Paralysis would be there, patient would not be able to breathe, and I am not able to secure the airway. So for this kind of circumstances, we have a very good reversible agent, a direct reversible agent available. That's called Sugama Dex. Sugama Dex is a direct reversal agent which can directly bind to the rocuronium and immediately reverse its effect. And when we use it for a, let's say, profound block, when we use it for a very intense block, immediately rocuronium is given and the block is very intense block, okay? Then we need to give it in a very high dose, okay? So Sugama Dex in a dose of 16 milligram per kg body weight would be the right answer. So I'm writing here a little bit about Sugama Dex. Sugama Dex. So Sugama Dex, that is sugar, SU for sugar, and it's a cyclodextrin compound. This is a direct reversal agent. This direct reversal agent can bind to only aminosteroid neuromuscular blocker. Aminosteroid, that is PAN, PPE, VEC, ROC, and rabacuronium. Aminosteroid. And in aminosteroid also, it acts best on rocuronium and on vecuronium. So these two have a direct reversal agent in the name of Sugama Dex, which can immediately reverse. If the block is intense, I mean, I have given and immediately I have to reverse it. Then we give it in 16 milligram per kg body weight. If the block is moderate, I mean, after, let's say, 20-25 minutes, I'm trying to reverse it, moderate block. Then we give it in 4 milligram per kg body weight. And if the block is mild block, then we give it in 2 milligram per kg body weight. So why I am giving you the doses? Because last time in INICET exam, question was asked on Sugama Dex. So maybe if they go one step further, they can ask the dose for mild, moderate, and intense block. Since it's a new drug and very commonly we are using it for reversal. Okay, so keep the dose in mind in case it is asked. Not very difficult to remember. 2 for mild, 4 for moderate, and for intense 6 milligram per kg body weight. It's a direct reversal agent, Sugama Dex. So answer is A for 8. Coming on the 9th question. Which of the following device delivers oxygen concentration between 0.25 to 0.45, that is FiO2 between 0.25 to 0.45, independent of patient's breathing pattern? So guys, this is the most important thing that you need to consider. Independent of patient's breathing pattern. So independent of patient's breathing pattern, this means the device. Anyone can tell me that your oxygen delivering devices can be divided into what types? Can anyone put in the chat box? I want to see how much is your knowledge on oxygen therapy devices, and accordingly I would add. So tell me that oxygen delivering devices, they are divided on what in two groups on what basis? The basis of their division. So can Sanjay or Vishwas or Sam can answer this? Okay, you can put in the chat box while I'll continue. Okay, so guys, your oxygen delivering device can be divided into two types. Number one is variable FiO2, low flow devices. And the second is fixed FiO2, high flow devices. Okay. Now, variable FiO2 delivering device. This is one question which is very commonly asked in exam. Variable FiO2 delivering device. This is dependent on patient's breathing pattern for delivering the FiO2. So they depend on breathing pattern of patient for oxygen delivery, right? And fixed FiO2 delivering device is independent of patient's breathing pattern. Okay, patient's breathing pattern. Got it? Okay. Low flow means the maximum flow in low flow is 15 liter per minute. So it cannot give more than 15 liter per minute. High maximum flow is your 60 to 70 liter per minute. Okay. So this is how the devices are divided. In variable flow, fixed FiO2, low flow, variable FiO2 delivering device. Low flow, variable FiO2 delivering device. We have nasal cannula, right? We have simple face mask or Hudson mask, simple face mask, and we have your non-rebreathing mask, that is mask with a reservoir bag, non-rebreathing mask. These are low flow devices. And in high flow fixed FiO2 delivering device, we have, what are the devices? We have Venturi mask, we have high flow nasal cannula, we have bag, the manual resuscitator, right? Which that is Ambu bag popularly called, right? These are high flow fixed FiO2 delivering device. So if I come back on the question, it's a very simple question. Independent of patient's breathing pattern. So independent means it cannot be variable FiO2 delivering device because it is dependent on patient's breathing pattern. And what are the devices? Nasal cannula or variable FiO2, simple face mask, and non-rebreathing mask. So guys, nasal cannula is dependent on patient's breathing pattern. Simple face mask is dependent on breathing pattern. Non-rebreathing mask is dependent on patient's breathing pattern. So what is independent of patient's breathing pattern is Venturi mask only in the option, which is fixed FiO2 delivering device, because it is based on Venturi principle, and depending upon the flow and the orifice in the barrel, a fixed FiO2 and a high flow is delivered to the patient. Got my point? So Venturi mask is high flow fixed FiO2 delivering device. And these three are low flow variable FiO2 delivering device. So very important. Remember this. So just very quickly, nasal cannula can give from 24% to 44% oxygen concentration by flow varying from 1 to 6 liter per minute. Your simple face mask gives 35% to 55%. Just remember 0.33 to 0.6, right? Venturi mask can give from 0.24 to 0.60 FiO2. This is the range of FiO2 they can deliver. Non-rebreathing mask can give from 0.8 to 0.9 FiO2. Guys, another very important question. Which of the following device with these four devices in the option can give highest FiO2? Answer is non-rebreathing mask. So here it is not asked dependent on patient breathing pattern or independent, just which delivers highest FiO2. So you have to choose the device which delivers highest FiO2. Answer is non-rebreathing mask. Any confusion on these questions? Refer the videos on our video on the oxygen therapy. You will have a crystal clear view on these questions. These are very important topics and you need to have a crystal clear information on these topics. These questions are very frequently asked. Okay, now coming on the next question. So these are again few devices. You can see this is HFNC, high flow nasal cannula. Before coming on next question, this is high flow nasal cannula, two nasal cannula attached to the blender. This is non-invasive ventilation. Patient interface is a mask, and this is manual resuscitator. So for image-based question, I have given these images so that you recognize the device. Now, HFNC can give FiO2 between 0.21 to 1, from 21 to 100%. NIV can give from 0.21 to 1, and manual resuscitator can also give from 0.21 to 1. So they all can give a fixed FiO2. They all are fixed FiO2 delivering device, right? From 0.21 to 1, whatever we fix, independent of patient's breathing pattern. Okay, next question. Which of the following is the best fluid for perioperative fluid supplementation in pediatric? So nowadays I am seeing a trend, question being asked, best fluid in adult, best fluid in pediatric. So guys, for adult and pediatric fluid, you all know crystalloid and colloid. We have for fluid, we have crystalloid and we have colloid. Now our basic fluid is your balanced crystalloid solution. That is the fluid which we use is in perioperative period. In what? In perioperative period is your isotonic crystalloid. So this is the basic fluid which we are using, isotonic crystalloid. And in isotonic crystalloid, what are the example of isotonic crystalloid? So for isotonic crystalloid, what are the options? What are the fluid available? Normal saline, your Ringer's lactate, your other balanced salt solution, right? Now guys, the better fluid which has the electrolyte composition near the plasma electrolyte composition is your Ringer's lactate and balanced salt solution. So these are the preferred one as their serum, their electrolyte composition. The electrolyte composition is similar to patient's electrolyte composition. So these are the preferred fluid. Now from ages we are hearing that in pediatric we should add dextrose. So nowadays for every patient dextrose is not what we are preferring to add in pediatric patient, but if we need to add, 2.5% dextrose is what is recommended. So what are the options for pediatric? Now N by 5 with 25% dextrose, incorrect. Balanced salt solution with 2.5% dextrose, this is correct. So for adult and pediatric, if I make the things crystal clear for you, for adult, which is the best fluid we use? Balanced salt solution with no dextrose. For pediatric, what is the best fluid used in perioperative period? The balanced salt solution plus 2.5% dextrose, right? So this is the fluid of choice. So this is being asked, this is the fluid of choice. And what is the most preferred way of giving fluid? By peripheral IV cannulas, right? Okay, next question. In the following image of capnography, what does phase 2 represent? So this is the phase 2, that is from B to C. What does this represent? So guys, phase, let's say A to B, B to C, C to D. These are the phases of inspiration. What is capnography? Your capnography is CO2 graph versus time. It is CO2 versus time. So we get a graph, right? We get a graph of carbon dioxide against time. And this one graph is representing one respiratory cycle, that is inspiration and expiration. Okay. Now, this graph has been divided into 4 phases, right? So let's say this is your endotracheal tube, this is the circuit, and the capno is a device which we attach between these two. This is airway, this is circuit, and this is the capno. This device has capability to detect carbon dioxide. So when the patient's respiratory cycle, patient is in inspiratory phase, then during inspiratory phase, the gases from the circuit will go into the airway. We will give the gases to the patient. This has no carbon dioxide. So during inspiration, the CO2 will be on the baseline. So when the patient is in expiratory phase, the first expiratory gas which comes out of the airway of the patient to the circuit is dead space gas, which does not have any carbon dioxide, so no CO2. So expiration has started, but CO2 is still 0. Now, then the gases from the behind the airway, that is alveolar space, starts mixing. So dead space plus alveolar gas. When the alveolar gas mix with the dead space gas, the when the, let's say, the alveolar gas, sorry, the graph gone, I will just again draw it. This is the inspiration, this is expiration. Okay. So I said respiratory cycle, inspiration, no CO2, no CO2. During expiration, first phase of the graph is your dead space, which has no CO2. Okay. So second phase, dead space plus alveolar gas. So CO2 starts getting added. So CO2 is increasing. Now, third phase, what happens? Only alveolar gas, only alveolar gas. So what happens? A fixed CO2. Here, expiration finishes, inspiration. Again, the CO2 touches the baseline. So we divide the phases into 1, 2, 3, and 4. Okay. Phase 1 to 3 represents expiration and phase 4 represents inspiration. So if you see 1 represents the dead space, right? 2 represents dead space plus alveolar, 3 represents only alveolar gas, and 4 represents inspiration. Okay. So phase 1 is dead space, phase 2 is dead space plus alveolar. So answer is dead space plus alveolar ventilation. So this was our 11th question. Okay. So answer is, and they can put arrow on any phase and they can ask what does it represent, which is asked in latest one of the exam. So keep it in mind. Okay. Okay. 12th question, concerning non-invasive ventilation, all are true except the non-invasive positive pressure technique has an advantage over CPAP for patients with cardiogenic pulmonary edema. Non-invasive ventilation may be beneficial for all patients who develop respiratory failure post-extubation. Non-invasive ventilation may facilitate the discontinuation of assisted ventilation in patients with COPD and cardiogenic pulmonary edema. It is worth persisting with non-invasive ventilation even when no early improvement is demonstrated. Guys, what do we mean by this non-invasive? Non-invasive ventilation. We mean by non-invasive ventilation is that the patient's interface is a mask. What do I mean by invasive ventilation? Invasive ventilation means the patient's interface is a tube. Patient's interface is endotracheal tube. Got my point? So when the patient's interface is mask, okay, then we call it non-invasive. And guys, we try to put a patient on non-invasive ventilation because it has minimal chances of, it has less chances of infection. So ventilator-associated pneumonia is decreased if with non-invasive ventilation. So always we give the patient chance with non-invasive ventilation. And there are 2 disease conditions for which non-invasive ventilation is most effective and has been indicated. So I'm saying the non-invasive ventilation is most indicated for bronchial asthma in acute exacerbation. It has proven benefit. We use BiPAP for the non-invasive ventilation, the BiPAP mode, and for cardiogenic pulmonary edema, we use CPAP. So for these 2, the non-invasive has a proven benefit. And for these two, we always start with non-invasive. But if the patient doesn't improve on non-invasive ventilation, then we have to immediately change it into invasive ventilation. We cannot postpone it for the longer. Patient will deteriorate further. Got it? Okay. So D is the wrong option, that we cannot persist with non-invasive ventilation even if there is no early improvement demonstrated. We have to change it from non-invasive to invasive. There are a few more questions which can be asked on it. Non-invasive. First, contraindication of non-invasive ventilation, which was asked in one of the recent exam. If patient has a threat of immediately going into cardiac arrest, need for emergent intubation, patient is in cardiac or respiratory arrest, we cannot put a patient on non-invasive. We have to intubate, put the patient on invasive ventilation. If the patient is in coma, patient has decreased consciousness, right? The risk of aspiration is high. Patient is unable to clear the secretion. The risk of aspiration is high. Patient is uncooperative, then the non-invasive would fail. So relative contraindication, that non-respiratory organ failure, which is life-threatening, severe encephalopathy, severe upper GI bleeding, hemodynamic instability, patient has facial trauma, significant airway obstruction, inability to protect the airway, anticipated prolonged duration of ventilation, and recent esophageal or gastric anastomosis, multiple contraindication, these multiple contraindication, right? Guys, just to simplify it, this is the whole list which I have put, but I will simplify it for you. If a patient has a threat of going in cardiac arrest or respiratory arrest, always invasive ventilation. Absolute contraindication for non-invasive. If patient has decreased consciousness, right? Patient is in coma, then we always go for non-invasive ventilation. You are getting my point? It's non-invasive is contraindicated because we need to have conscious patient for non-invasive. Unconscious patient cannot protect the airway from aspiration. So kind of absolute contraindication for non-invasive ventilation. So decreased consciousness, coma, inability to clear secretion, these are all absolute contraindication of non-invasive ventilation. Just remember these three. This is most commonly asked in exam. Then criteria for terminating non-invasive ventilation and switching to invasive. If patient is getting worsened, if the respiratory rate increases very much, if hemodynamic instability happens, if the consciousness of the patient starts decreasing, patient is unable to clear the secretion and the mask which you have attached, patient cannot tolerate it, immediately we change into invasive ventilation. Got it? So we should have a low threshold for converting non-invasive to invasive if these things are present. So answer would be that it is D, which is the incorrect answer. Right? Coming on 13th question. Identify the procedure and name the drug which is contraindicated. So two questions in one question. First, we need to identify the procedure. So there is a double tourniquet, a IV cannula, and through that IV cannula, 0.5% lidocaine, a local anesthetic is being given. So by IV route, I am giving a local anesthetic. It's IVR, intravenous regional anesthesia, or we call it Byers block. Intravenous regional anesthesia. Intravenous regional anesthesia. Or we call it Byers block. We call it Byers block. Remember, right? So Byers block is the name given by due to Dr. August Bayer, the person who came up with this block. The person who came up with this block was Dr. August Bayer. Got it? Okay, remember. So that's why it is called Byers block. Okay. So just a second. Okay. Okay. So guys, Byers block, IVRA. So isn't it a bit a contradictory thing? What is this IVRA, intravenous regional anesthesia? IVRA is a special regional anesthesia in which only the one particular limb is blocked by putting a tourniquet on the limb and giving the local anesthetic instead of locally, intravenously. So when we are injecting the local anesthetic intravenously, there's always a risk if the tourniquet gets loosened, the drug can go into systemic circulation. So the safest local anesthetic would be local anesthetic of choice, that is lidocaine, lignocaine. That's the local anesthetic of choice. And the unsafest local anesthetic, which has the risk of high toxicity, should be avoided. And that is our bupivacaine. So remember, for IVRA, intravenous regional anesthesia, which is also called Byers block, on the name of the person who discovered it, Dr. August Bayer, right? In this, the local anesthetic of choice, which is very commonly asked, is lidocaine, and local anesthetic contraindicated, very commonly asked, bupivacaine. So here they have asked which is contraindicated. So answer is it's the Byers block, and contraindication is bupivacaine. Okay. Coming on the 14th question. All of the features of second generation supraglottic airway device except second generation supraglottic airway device, remember, has all the benefits of the first generation supraglottic airway device, and it has a additional benefit that it is comparable to ET tube in preventing aspiration. Guys, depending on when they were discovered and what are the features, the supraglottic airway device is divided into first generation and second generation. First generation supraglottic airway device are the devices which has one simple airway tube for ventilation. And in this comes your classical LMA or laryngeal mask airway, classical LMA, your flexible LMA, the unique LMA which we use, disposable LMA which we call it, and cobra perilaryngeal airway. Just remember in this, don't go for so detailed. Just remember classical LMA or simply LMA. Second generation, in which a drain tube was added, drainage tube was added. ProSeal LMA, iGel. These two devices, just remember, ProSeal and iGel. Now these have extra drainage tube. Now second generation has all the benefit of first generation. What were the benefits of first generation? Easy to insert, fast to insert. Yes, second has that benefit. It can be used as an airway device in laparoscopic surgery. Guys, second generation is comparable to ET tube in preventing aspiration. So for elective laparoscopic surgery, we can use it. Yes, so this is also correct. It is comparable to ET tube in preventing aspiration, correct. That's an additional benefit of second generation because it has a drainage tube which can also aspirate the gastric content. It requires deeper plane of anesthesia to tolerate the second generation. No, LMAs need a lesser plane compared to ET tube for tolerating it. So this is incorrect, right? Second generation or first generation needs lighter plane for tolerating it, lighter plane. That's another benefit of supraglottic airway device. They don't need a very deep plane of anesthesia. They can be supported with lighter plane. So this is incorrect. So remember these examples for first generation, classical LMA, for second generation, ProSeal LMA with two tubes. This is what you have to remember. And iGel airway. These are the two devices which you have to remember for second generation, which has gastric channel added to it. Okay. So only classical LMA for first generation and ProSeal for second generation and iGel for second generation. Okay. Coming on the next question. Okay. Identify the procedure being done in the image. So what is the procedure being done in the image? So palm, right? We are putting pressure on two of the arteries, radial and the ulnar artery, and then releasing the pressure one by one and seeing the color of the palm being returned. This is Allen's test, which has been asked in exam. Now, Allen's test is done to see the superficial and deeper palmar arch work, the efficiency of the superficial and deeper palmar arch of radial and ulnar artery before cannulating the radial artery for invasive blood pressure monitoring. Got it? So for invasive blood pressure monitoring, right, we cannulate. The most common artery cannulated is radial artery, because it is superficial and it has a very good arcade with the ulnar artery, right? So we use radial artery. So there are few tests which we can perform to see the patency of this superficial and your deeper palmar arch, superficial palmar arch and deeper palmar arch between radial and ulnar artery. So one of the tests is Allen's test. So the image describes the Allen's test. The other test would be your barbecue test. Barbecue test is like Allen test. The only difference is here we attach a pulse oximeter and see whether whether on applying the pressure and releasing the pressure, the trace of the pulse oximeter goes or not. So Barbeau test, we attach a pulse oximeter. So if in the same kind of let's say image, a pulse oximeter is attached, the answer would be Barbeau test, right? So we apply the pressure and we see the tracing of the pulse oximeter, right? Same way we do Allen test, we perform the Barbeau test also. We blanch the limb and then we apply pressure on radial and ulnar artery, release the pressure and see the graph of the pulse oximetry. So this is Barbeau test. So this is a quick procedure that determines patients is good candidate for the radial access. It assesses the patency between radiopalmar arch of the patient's circulation. We place a pulse oximeter on the index finger or the thumb of the patient, compress the radial ulnar artery simultaneously, release the ulnar artery when the waveform is flat for 2 cycles, and watch for the waveform to return. If the waveform returns, we have a very good arch between the radial and palmar radial and ulnar artery, right? So that's the Barbeau test. So Roos test is the test by which it's a provocative maneuver for diagnosing thoracic outlet syndrome, right? That's the Roos test, okay? So remember, this without pulse oximetry is Allen test to see which we do before the radial artery cannulation, okay? Okay, next. Next is 16th question. A 72-year-old male posted for non-cardiac surgery is diagnosed case of moderate mitral stenosis and mild mitral regurgitation. It is required to do induction with a cardiostable anesthetic agent. All true about IV anesthetic agent and cardiovascular system except. So already we have discussed the explanation for this. Etomidate is a cardiostable intravenous anesthetic agent. This is true. Propofol causes hemodynamic instability, which is true. Thiopentone is cardiovascular depressant. True. Ketamine is agent of choice in cardiac surgery. False. Now, this is incorrect, right? See, ketamine is only used in one cardiac condition, that is cyanotic heart disease. Cyanotic heart disease. Ketamine is cardio unstable. Why we use it in cyanotic heart disease? Because it can maintain the systemic pressures. That's why we use it in cyanotic heart disease. Got my point? So only for cyanotic heart disease, ketamine is agent of choice in cardiac condition. Otherwise, we try to avoid ketamine for cardiac diseases. All right? So this is incorrect. Ketamine is cardiodepressant. So remember, thiopentone and propofol, cardiodepressant, cardio unstable on cardiovascular system. Etomidate is cardio stable. Ketamine is also cardio unstable. So ketamine is also cardio unstable. It increases blood pressure and heart rate because of its sympathetic stimulation effect. And in absence of catecholamine, it is myocardial depressant. So cardio unstable. So keep it in mind. Okay, next question. Okay. A 45 years old brought to emergency with high fever and respiratory distress and altered consciousness. Patient was put on IV antibiotic and intubated. Half an hour after intubation, saturation decreased, capno reading changed from 39 to 54, airway pressure increased, and following change is noticed in capnography reading. On auscultation, there was a bilateral decrease in airway entry, probable diagnosis. So if I see this graph, this is shark fin pattern of capno, right? I see this graph, and this graph is telling me partial obstruction. Answer has to be bronchospasm, right? In bronchospasm, we get a shark fin pattern. So remember, what will happen in bronchospasm? In bronchospasm, the caliber of the airway would decrease in partial bronchospasm. The caliber of the airway will decrease. So the airway caliber has decreased. So airway pressure increases, saturation decreases, and the graph of EtCO2 becomes shark fin pattern with the final value of capno becoming higher. So in my patient, the EtCO2 increased, saturation decreased, airway pressure increased, and there was a bilateral decrease in air entry, which is pointing towards bronchospasm. So answer has to be bronchospasm. In pulmonary edema, there would be symptoms like frothy sputum, EtCO2 would never increase. In endobronchial intubation also, saturation would decrease. EtCO2 can increase, but once tube is fixed, the forward migration of the tube is possible, but bronchospasm is a better answer in this case, right? Though it's possible, but compared to bronchospasm, and compared to it, bronchospasm is a better answer. In pneumothorax, there's a dramatic increase in the airway pressure, right? There's a dramatic increase in the airway pressures. Saturation can decrease, but EtCO2 will not increase, right? So answer is bronchospasm. Okay, keep it in mind. Okay, next. A 48 years old ASA grade 2 patient being operated for laparoscopic cholecystectomy, all of the following monitors should be attached in intraoperative period except. So what we attach for monitoring in intraop period? Guys, remember, right? Remember, very, very clear in your mind that for every patient undergoing any surgery, we have to attach some basic monitors. We have to attach some basic monitors. We have to attach ECG. We have to attach capnography. We have to attach the SpO2 probe. We have to attach the NIBP, non-invasive blood pressure monitor, and we have to attach the temperature probe. These are the basic monitor. In case of patient undergoing GA, along with basic monitor, we can also attach BIS monitoring, which monitors the intraoperative awareness, and neuromuscular monitoring, which monitor the adequacy of neuromuscular paralysis. So these monitors for a patient under GA, I would try to attach in every patient. Any other monitor apart from this, I would only attach if there's a special requirement because of patient's comorbidity and because of special surgery we are performing in the patient. Otherwise, we will never attach. We will never attach any other monitor. Got my point? So just keep in mind, my patient is ASA grade 2. For ASA grade 1 and 2, no special monitor. No special monitor required according to the patient's comorbidity. And the surgery is laparoscopic cholecystectomy. So no special monitor. So what we will attach is only the basic and the 2 extra desirable monitor which we use in general anesthesia, right? BIS and neuromuscular monitoring. These are basic monitor which we always have to attach. And if the patient is under GA, BIS and neuromuscular monitor is the desirable monitor which we attach, right? So let us see, capnography is the basic monitor we have to attach. Neuromuscular monitoring is a desirable, I will attach. BIS monitor is a desirable, I will attach. Invasive blood pressure monitoring, we don't attach. Why? It is only attached if I am suspecting that patient will have a profuse blood loss and drop, or if the patient is hemodynamically unstable, ICU patient, then only I will attach invasive blood pressure monitoring. Why would I attach an invasive blood pressure monitoring in laparoscopic surgery? This is not a special surgery. And why in ASA grade 1 and 2 patient? No, not at all. So invasive blood pressure monitoring is only required if I'm suspecting that the surgery for which the patient is getting operated, it will have a huge intra blood loss, and patient, if my patient is hemodynamically unstable, which is not in my question. So answer is D. Got it? Okay. So it's a very simple question, and these kind of questions are very frequently asked. So keep it in mind. Okay. Next. Now, again, an image-based question. So this is the pipeline. Which safety system of machine prevents incorrect attachment of following? So what following? First, we need to understand this is pipeline. We can see the color coding of the pipeline. So this is blue for nitrous oxide, white for oxygen, yellow is for no gas, it's vacuum, and this is black for air. And it is attached to our anesthesia machine by which safety system? Something called DIS, diameter index safety system, right? Pinned index safety system is for anesthesia gas cylinder. It prevents the incorrect attachment of cylinder to machine. Hypoxia guard prevents hypoxic mixture from machine, right? And this is something which prevents incorrect attachment of pipeline to the anesthesia machine. And shredder attachment is a special attachment which prevents incorrect attachment of pipeline to the wall of the operating room, right? So answer is your DIS. Ravi, it should be DIS, not pin index, right? Pin index is for your gas cylinder. This is pipeline, and for pipeline, it is DIS, a very probable question. So answer is DIS. Coming on the 20th question. Well, simple, I would just shorten the question. A 24-year-old patient was given spinal anesthesia. She was kept in left lateral position. Anesthetist was to be given spinal anesthesia, was giving a hyperbaric drug. So just in one line, I'm shortening the question. Why do we use hyperbaric local anesthetic for spinal anesthesia? Guys, for spinal anesthesia, we are using hyperbaric local anesthetic. Why? Now, to provide nutrition to the spinal cord cells? No. Why do we need special nutrition suddenly? High density and high baricity to reduce the headache, to reduce the bleeding. So why we add dextrose as an additive to the local anesthetic to make it hyperbaric? We get a preformed form. We use a hyperbaric local anesthetic. It makes the drug more dense, increases its baricity, and prevents its high spinal, prevents high spinal to happen. So that's why for spinal anesthesia, the local anesthetic which is used, it is always mixed with dextrose to make it hyperbaric. So most common drug used for spinal anesthesia is 0.5% in India, hyperbaric bupivacaine. Keep it in mind. So why we are using it? To prevent high spinal to happen. Right? So answer is B. Okay, coming on 21st question. A 5-year-old male twin presents with acute appendicitis. He is scheduled for emergency appendectomy. His family history is significant, for his twin brother suffered from malignant hypothermia episode that led to 2-week intensive care unit stay. Simple. He has a family history of malignant hypothermia. Which of the following drugs should be avoided? So a twin brother of the patient had a history of malignant hypothermia. Which drug should be avoided? So drug which precipitates malignant hypothermia. So what are the triggering triggers of malignant hypothermia? 3 important drugs we need to remember. Number 1 is your succinylcholine. This is the most potent trigger, a depolarizing neuromuscular blocker. Number 2, your volatile anesthetic agents, right? They are again a trigger of malignant hypothermia, the xalothane, the isoflurane, the sevoflurane, the desflurane. So halo, iso, sevo, des, all, right? And number 3, lignocaine, a local anesthetic, can trigger malignant hypothermia. So nitrous oxide, carrier gas, it is not triggering malignant hypothermia. Rocuronium, a non-depolarizing, doesn't trigger malignant hypothermia. Xenon doesn't trigger malignant hypothermia. Desflurane has to be avoided in this patient. So these 3 are the triggering drug for malignant hypothermia: succinylcholine, volatile anesthetic agent, that is halothane, isoflurane, sevoflurane, desflurane, not nitrous oxide, not xenon, and lignocaine. So you have to remember this. Very, very important question. Okay, next question. A 57-year-old female posted for laparoscopic cholecystectomy. She had a medical background of type 2 diabetes, which HbA1c 8.5%. She also has a history of heart problem and is dyspneic while doing normal household work and also at rest. She belongs to ASA grade. Patient has diabetes, heart problem, and both are uncontrolled. Her diabetes 8.5 HbA1c, uncontrolled diabetes. She's dyspneic even at rest, uncontrolled heart disease. She has life-threatening heart disease. She cannot perform her day-to-day activity as well. She's even dyspneic at rest. She has uncontrolled diabetes. She belongs to ASA grade 4. So ASA grade 4 is life-threatening systemic illness. She is ASA grade 4. Anyone has any doubt in ASA grading? Because again, a very probable question. ASA grade 1, no systemic illness. ASA grade 2, mild to moderate systemic illness. And ASA grade 3, moderate to severe systemic illness, right? Word severe would be necessary to go for ASA grade 3 if severe is there, right? And what kind of physical activity can cause problem in ASA grade 3? Physical activity which is more than your normal household activity. So during walking on the stairs or during running, if someone becomes dyspneic, normal distance on running, then it is ASA grade 3. But normal activity would not produce any symptoms, right? Normal activity producing symptoms is ASA grade 4. Normal activity producing symptoms is ASA grade 4. And no symptoms on any activity is ASA grade 2. No comorbidity is ASA grade 1, right? So no chances of any mistake in ASA grading, a very, very expected subtopic from pre-anesthetic evaluation. Next question. A 17-year-old male underwent a nerve block with bupivacaine. 5 minutes after the procedure, patient was dizzy and agitated. Next best step in management. So we gave him a block and the patient became anxious and is dizzy. Mostly immediate diagnosis we will suspect is local anesthetic systemic toxicity. And the antidote for it is 20% intralipid emulsion. So we will start the lipid emulsion and put the patient in close monitoring. Guys, local anesthetic systemic toxicity, right? Local anesthetic systemic toxicity. Okay, Sam, I would just come on this question once I discuss this one. Local anesthetic systemic toxicity, we have to think of two systems with predominance in my mind, CNS and CVS. CNS, the symptoms would be the patient will become agitation, there would be agitation, there would be the circumoral numbness, right? There would be your seizure, which can be seen in the patient, twitches, which can be seen in the patient. Now, these are the conditions which can be managed. Cardiovascular toxicity is very life-threatening. It produces arrhythmia, and cardiac arrest. It can cause cardiac arrest because local anesthetic can block the sodium channel, and sodium channel is present in CNS and CVS. And if it is systemically absorbed and these sodium channels are present, it can be life-threatening. And the management is always you do the symptomatic management, whatever symptom is there, and you give 20% intralipid, right? Intralipid emulsion infusion. This is antidote for LAST, local anesthetic systemic toxicity. So whenever nerve block is given and we get some features of local anesthetic systemic toxicity, we can start lipid emulsion. It will improve the patient, right? Okay. So this is, remember, LAST, they very frequently asked an exam. Okay. Next question. A special vaporizer specially designed for inhalational agent with low boiling point and high vapor pressure. So a special vaporizer specially designed for an inhalational agent with low boiling point and high vapor pressure. First, you need to identify that so question requires identification of that inhalational agent. Answer has to be your desflurane. Desflurane is a inhalational agent which has lowest boiling point and highest vapor pressure. So this is the vaporizer for the different inhalational agent. First three vaporizer are similar except with a different color coding, and this is a special vaporizer of desflurane. Special vaporizer of desflurane, right? This desflurane special vaporizer, why we need? Because it has lowest boiling point and highest vapor pressure. Lowest boiling point and highest vapor pressure. So it needs a special vaporizer. This is a Tech 6 vaporizer. Tech 6 vaporizer. Other agent, same kind of vaporizer, right? But we cannot mix one agent in other agent's vaporizer. So we have a color coding. So yellow is for sevoflurane, purple is for iso, and red is for halothane. And even DES has been given a blue color code, right? So color coding is also important. So remember this, okay? So remember, halothane, iso, and sevo, the boiling point is 50 plus minus 2 degrees Celsius, DES 23 degrees Celsius, the boiling point. Halothane, iso, sevoflurane, the vapor pressure is 270 mm of Hg. Desflurane, 770 mm of Hg. Because of these two features, needs a special vaporizer. And the example I showed you, that is your Tech 6 vaporizer. Okay. Now coming on the next question, the last question. A 28-year-old male getting a wound debridement done under ketamine. After completion of the procedure, during emergence, the patient become violent with visual and auditory hallucination. So we call this what? After ketamine, one of the very common complication which we see is emergence delirium. Emergence delirium, right? What is this emergence delirium? So when the patient is getting recovered after ketamine, what happens? Patient has a visual and a like tactile hallucination. Patient feels as if bugs are on his body, or patient can see some imaginary creatures in front of him. This makes the patient very, very agitated. So that's called emergence delirium, right? Dissociative anesthesia is a special anesthesia produced by ketamine at low dose. At low dose. This causes the dissociation of thalamus and cortex. So we get a pain-free patient who is conscious but not oriented in time and place. Emergence delirium is seen something post-op after ketamine anesthesia. Got it? So answer is emergence delirium. Just a quick, very quick point I just want to tell you is that for ketamine, the most common post-op side effect we need to remember is emergence delirium. And for etomidate, the most common side effect which we need to remember is adrenal gland suppression, adrenal cortex suppression. For propofol, the most common side effect we need to remember is nausea, your pain on IV injection, pain on IV injection, right? So remember, when we use these agents for anesthesia, these side effects we have to consider. For etomidate, adrenal gland suppression, propofol, pain on IV injection, and for ketamine, emergence delirium. Remember, ketamine is the only IV anesthetic. Ketamine is the only IV anesthetic which causes analgesia, which produces analgesia, which is very commonly asked in exam. And propofol is the only IV anesthetic which decreases nausea and vomiting, post-op nausea and vomiting. It is anti-emetic, anti-emetic. That's the beauty of propofol, right? So very good for daycare surgery, for neurosurgery, for thoracic surgery. Propofol is a wonderful IV. If nothing comes in your mind, patient is cardio stable and best IV anesthetic agent, propofol. Remember, propofol. Got my point? Just a trick. Okay, just a trick. But of course, you will know, we have already discussed where they are agent of choice. So only issue with propofol is cardiac instability. Otherwise, it's a beautiful agent. Got it? So this was our last question, right? So I just saw a few questions. Ravi, ma'am, please explain about free flow oxygen delivery to newborn baby. So I couldn't get your question, Ravi. Free flow oxygen delivery. I mean, for newborn baby, normally oxygen supplementation is done through either oxygen tent or oxygen hood. If we want to give a higher oxygen concentration, we use oxygen tent, and lesser oxygen concentration, we use oxygen hood. Okay. Then Hala. He has asked epilepsy. So I couldn't, there is no question. Sam asked about, is cough and cold ASA grade 1? See, Sam, if patient has cough and cold, it's not a systemic illness. So cough and cold, on the basis of cough and cold, we cannot classify the patient in ASA grade. And patient having a cough and cold, we don't take for elective surgery because their airway is hyperreactive, and on manipulation, the airway complication can happen. So once the cough and cold subside, then only we take the patient for surgery, for elective surgery. Emergency, we cannot do anything. We nebulize and we take a risk and we take the patient for surgery. But cough and cold is not a basis on which ASA grading is done. It is done on systemic illness. Got it? Okay. So I hope it is enough to make you understand, Sam. So I think this will take care of your query. So I'm done with all the question, and these are the questions which please revise prior to going for the exam. And these are from the topics which I expect after screening all the recent year questions from all the exams, and I formulated these questions for you. I hope some of the questions from this paper which I have prepared for you comes in the exam and you have a great exam. My best of luck for your exam. Do good and come out with flying colors. My best wishes. Thank you so much. Thank you guys. Bye.